Like, as a group, you guys crushed it. What's that? Yeah. No retest, no yes and no. No, you guys absolutely crushed it, which is awesome. I don't have much to say. I mean, you guys did even better than I was hoping. So, great job to everybody here. Two of them that I'm going to talk to you about, right? Tell you what my thinking was on it. On the higher missed ones are kind of like the 50-50 ones. You're a debate, but just to kind of tell you where the thought process was, so you understand if you were between those two and you picked the right one or picked the wrong one. Okay? So the first one is the gallbladder with the HIDA scan versus the ultrasound. Okay? Let's go back to what we were talking about. HIDA scan was the functional study for the biliary tree. The ultrasound was the gallbladder. Yes, if you're concerned for a stone, right? But if you're concerned for a stone within the biliary tree, that's where your HIDA scan comes in. Stones in the gallbladder, still the ultrasound. That's that cholecystitis, that's that Murphy sign was trying to get you at. Was just the gallbladder. Because the gallbladder is not really functional. Even with the HIDA scan, right? We're not assessing the function of the gallbladder. Gallbladder just squeezes bile out. That's all it does. The HIDA scan looks at that biliary tree to make sure stuff is flowing the way it's supposed to. And there's a difference between those two, okay? So what led you towards that one, hopefully, was the Murphy sign, gallbladder, ultrasound. The other one, the pelvic fracture. Okay, go ahead.
Are you saying don't use a HIDA scan
For the gallbladder alone, no, you do not. No. If you don't have ultrasound as a choice, you can't do that, but we had ultrasound as a choice. So yes, many of these things you can use in replace of if something's not available. So to clarify that, yes. Can you use a HIDA scan to evaluate the gallbladder? Really what it's going to do is it's going to evaluate the biliary tree to make sure the gallbladder is doing what it's supposed to be doing. It's just not the best study to evaluate the gallbladder itself. So yes, it can be used if for some reason you have nuclear medicine department and all your ultrasounds are broken for some reason, which could happen. So if you're in a small facility that only has one machine, it has to be down for maintenance, right? So you can use it, it's just not preferred. Yeah. Pelvic fracture. Don't throw things at me. Okay? Don't throw things at me. The idea on that one was, reading that one a little bit carefully, I wasn't asking you to evaluate for the pelvic fracture. I was asking you to evaluate the unstable patient, right? With the suspicion that you have a pelvic fracture. If you think you have a pelvic fracture, but you're evaluating the patient, an x-ray is not going to tell you anything about the significance of the damage for the patient and why they're unstable. On top of that, that's the initial study, right? I wanted study of choice, which then brings you down between CT or ultrasound. CT or ultrasound. I recognize that on the actual slide, study of choice wasn't labeled between either of those, but unstable and stable is what we're supposed to go to next, right? Unstable, EFAST or ultrasound, stable, CT. And that's kind of what I wanted. I think some of you kind of was like focusing on the pelvic fracture part. It was like, oh, I'm evaluating the pelvic fracture, so we're going to get an x-ray, right? So there were two things in that question to get you away from pelvic x-ray. One was study of choice, not initial study. And two is I wanted you to eval the patient, not eval for a fracture. Now, those were the two, well, that one was one of the hardest questions on the test. It was designed to be a little bit more challenging. I could have made it really easy and then like an x-ray was already accomplished, but then that would have just pointed you right to where we needed to go, right? And so I use a question like that, not to necessarily trick you, but to get your minds thinking of how there are small bits of information within things that you got to kind of work through to get to. Because when you get to like junior semester sometimes, you're going to have a question to where you're like, well, it doesn't say it just like that on the slide. No, it doesn't. But if you take slide 45, slide 53, and slide the information on slide 67, that's all information you need to have. And if you knew all that information, then you could piece it together to get to this answer, right? So that's like a teaser, taster into like that senior semester. I think that's part of our responsibility here as well. But that's why there's only like one, maybe two. So it's not the make or break to cause people to do poorly or fail the course or anything like that. It's just meant to kind of put that out there, okay? Those were the only two that were really kind of lit or what we call high miss. Everything else was pretty solid, guys. So really strong work, honestly. Super proud of you guys. It was awesome. So let's take that momentum into chest and abdomen. Yeah, I'm getting nervous about it. We only got to do 2 body parts, the chest and the abdomen. That's it. We covered like 30 body parts. I'm just kidding. Okay, so going into block 2, more so than block 1. Yes, a lot of things look the same. We have 7 lectures, we have 8 lecture blocks. Because sometimes we go slower, sometimes we go quicker, just like the first block, okay? So a lot of things look the same. Your patient presentation is huge when we start getting into these abnormalities, okay? So make sure you know how the patients present in that aspect. But we're gonna start with chest. Also notice, 5 lectures on chest, 2 on abdomen, right? There's a lot that goes on in the chest, and there's a lot more detail in the chest than in the abdomen. So it doesn't mean that 80% of the test is going to be chest up and 20% is going to be abdomen. Don't make that correlation, right? But just know that the reason there is so many chest lectures is because there are more nuances. So details are important. Keep the questions coming. I truly think part of the reason you guys did so well on that first exam is you had a lot of good questions. You were very interactive. You helped ask me to clarify things, more so than different classes. Some ask questions, some don't. So, all right. 11 hours of just chest stuff, right? Whew. We'll get through it together. We're going to go through an introduction, heart and great vessels, airway, okay? Chest radiography, chapter 2 if you're doing the book. Here's all the stuff we're going to cover. I'm not going to read you the slide, but we're going to start from the beginning, just like we did for the MSK stuff. We're going to start with the basics, go over the image, go over the things you got to watch out for, break down what normal is, how do you see it, how do you look at it, train your eyes to see what you need to see. Okay? And we'll go through all of this. Common plane radiograph, usually in most cases, much like with MSK, it's the initial study. Generally. There are a few nuances which we will talk about when we get to them where it's not. But if you see anything where they're asking you the initial study, chest x-ray is probably right the majority of the time. Why? Again, because it's quick, right? And there's so much going on in the chest that even if there's something that I'm concerned about, that I want to get a CT or I want to get some other kind of study, I don't want to miss something else that's going on. And the x-ray can actually tell us a lot. X-ray in general is important for trauma, foreign body, but look at this, we're evaluating all these symptoms. Shortness of breath, chest pain, cough, hemoptysis, fever, weight loss. Why the heck would a chest x-ray fever and weight loss? Huh? Cancers, right? What's causing? I don't know. Let's check the chest x-ray just to make sure. The lungs are a common area for metastases, right? Cough, chest pain, shortness of breath, hemoptysis. Well, again, I don't know. Is there something in the lungs that's not supposed to be in the lungs? Or is there actually something wrong with the heart? So we're going to get a chest x-ray, and we're going to see that, and you're going to learn kind of what normal looks like. Hypoxemia, abnormal lung sounds x-ray, right? Pre-op general anesthesia. Why do you think we do a chest x-ray for pre-op? Make sure there's nothing in there that's not supposed to be, right? We also want to make sure that the lungs are large and viable. And how much harder do you think it is, or let me put it this way, how much more risk do you think there is intubating a patient, not the intubation part, but putting them to sleep for a surgery on somebody in this room versus somebody who's got really bad COPD, right? Much higher risk for that COPD patient. So the surgeons want to know ahead of time, what am I dealing with before I intubate this patient, put them to sleep to fix their ACL, or to take out their gallbladder, or whatever. Like, how hard is it going to be to wake them up afterwards, and is there a risk of oxygen saturation or issues with the lungs prior? That's really why we need a pre-op. Usually, you don't have to do a pre-op chest x-ray till like, it depends on the surgeon, 40 plus, 50 plus. Anybody younger than that, they're just like, well, you don't have those kinds of disorders yet, most likely, so we'll be fine. Follow-up procedures. So you'll see when you guys start to get to phase 2 and you start putting tubes in patients, whether it's an OG tube, an EG tube, a chest tube, anything along those lines, you're going to get an x-ray. because you want to make sure the tube's in the right spot, because you're just kind of guessing. Yeah, that's about right. Pull it back a little bit. Okay. X-ray will show you your line placement and show you that's where it's supposed to be. Lung biopsy and then pacemaker assessment. We won't get too much into that, but after you put a pacemaker in, same concept. Is it all in the right spot? Here's all the diseases that we can actually evaluate on a chest X-ray. And you can see cardiomegaly, large heart, stenotic valves, sometimes calcifications in the valves because they're so stenotic, but in reality, what we will learn is we will see certain areas of the heart enlarge due to stenotic valves, and it will make us think that there might be a stenosis there. Chamber enlargement, I just kind of mentioned. Sometimes vessel disease, pericardium abnormalities to include air within the pericardium, right? Or air within the mediastinum. We'll be able to notice that once we get through it, kind of work through it. Sequela from hypertension. Anybody know what they think would be a concern for long-standing untreated hypertension? What that would do to why we get a chest X-ray? So maybe pulmonary hypertension, but let's say it's not pulmonary. Let's say it's just regular hypertension. Heart what? Heart failure. We're going to talk about just heart failure. Left ventricular hypertrophy, right? From the heart working so hard for so long, it enlarges because it's a muscle, and you can see that on an X-ray. You can see that left ventricle being larger than it normally should be once you get used to seeing normals, right? We'll be able to see something. We'll learn about atelectasis, pleural effusion, pneumonia, abdominal air patterns. That's your COPD patients. We're going to learn about all these things in this block. Not today, just in this block. It's a lot for today. Remember this one? Okay. AB versus PA. We talked about it before, so we'll briefly cover it again. Majority of chest X-rays are done PA unless the patient physically can't. Like they're hospitalized in the ICU. They can't stand up. They're even in a wheelchair, you can still do this because you can move that board up and they can reel their legs right underneath and they can get their PA, right? So really, unless you're in an ER and you're doing it bedside or an inpatient, you're going to get a PA chest X-ray. All right? I will not expect you to interpret by looking at the X-ray and figure out on your own whether it's PA or AP. I will not. But I do need you to understand some of the abnormalities that can happen with the AP, i.e. the magnification of the heart, because if you have an AP X-ray, I will tell you it's AP. So that way you know in your brain, hey, if that heart looks a little bit larger than it should when we go over like what the size of the heart should be, oh, it's an AP X-ray. I expect that. That's not an abnormality. That's okay. But I'm not going to give you one and expect you to know. Because like you can see here in this picture, like I told you, before you see the image, we're going to flip it to the way it's supposed to be for you. So unless it's labeled, or really you ordered it that way, there is no way for you to know just by looking at it. So I will have to tell you if it's an AP chest X-ray or not. Don't get very many of them. Sometimes with some of these conditions that we talk about, the only decent X-rays are on really sick patients who are bedridden, so I have no choice but to do an AP, give you an AP chest X-ray on the test, but I will tell you it's an AP chest X-ray. But just understand why the heart is slightly enlarged, because of that shadow game we played with the magnification. Here is where I need you to live as you're starting to learn this stuff. This one and this one. Okay? You can go to Radiopedia, you can type in PA chest X-ray normal annotated to give you other viewpoints of this. I harped on anatomy last time, same thing for this one, and even a little bit more important in this block. Okay? So let's take a look at the anatomy a little bit. Let's start off with the big blackish, grayish tube right here. Why is that more dark? What's in there? Air. In what body part? Trachea, not the esophagus. That is the trachea. The esophagus does not have air in it unless you swallow the air, but the trachea always does. And especially considering the way we do chest X-rays, the patient is told to take a big deep breath in and hold it. So that trachea is filled with air as well as the lungs. So that is a trachea. It is not an esophagus. Okay? All right. What else we got on here? So, following down, we got our clavicles that come across here. So into our manubrium notch. And I know the black lines are on the heart, but following the sternum down. Okay? So clavicles, manubrium, the notch, sternum down. Heart anatomy. Look at the way the heart lies. The biggest part I want you to focus on here, I got my big old left ventricle sitting over here, right? Big old left ventricle poking out on this side of the spine. On the other side of the spine, this is your right atrium. It is not your right ventricle. Okay? It's because of the way the heart lies. And you'll see this on a CT image I'll show you in a little bit. The right ventricle is actually sitting directly behind the spine right here, which is why we can't see it. It's the way the heart lies. The heart is not this perfect left versus right there. So this gray soft tissue bulge on this side of the spine is your right atrium. Okay? When you come down the spine here, you look at some of these other ones, you'll see a bulge here, the aortic arch. Okay? Then your pulmonary trunk and vessels, then your left atrium, and your left ventricle. So here, aortic arch, pulmonary vessels, left atrium, left ventricle. Almost kind of makes like this little bump, 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 bump down on that side, right? Just kind of curves it in. Easier to see when you have this up on one area and a plain normal chest x-ray without the annotations on the other, so you can kind of look back and forth and kind of figure out where things are and what they're supposed to be. Knowing normal for this is massive because then you'll be able to see what jumps out at you. All right? So there's your heart stuff. A couple of things we'll cover more in the lungs when we get there, right? So you got your diaphragm that comes down into your costophrenic angles. Diaphragm down into your costophrenic angles. Now, the right diaphragm is a little bit higher than the left. Do you see that? Why is that? The liver. The liver is pushing this guy up. The liver is this massive organ that is pushing it up. Okay? Got a little air bubble sitting right here underneath the diaphragm on the left side. That is the only way we can tell the stomach is there. When they're standing upright, air rises, right? We almost always have a little bit of air in our stomach, for the most part, unless there's a tube in there taking it all out. That's your gastric bubble underneath here. Underneath that left diaphragm, it can be here, it can be over here. Just know if you see this small little bubble of air underneath the left diaphragm, that's your stomach, that's your gastric bubble. Okay? We'll go over the main bronchi when we get a better picture. It doesn't have all the annotations on it. We'll cover ribs a little bit later. But the biggest thing on this one is looking at that heart, understanding the areas of the heart that you can see on this x-ray. So again, what are we missing on the PA? We're missing that right ventricle. We cannot see it. Laterals, typically done as a left lateral, which is why you always see left. Remember, that doesn't mean this is the left lung. The lungs are superimposed on one another. I can't tell you which lung I'm looking at here. It's both of them. The reason we do the left lateral, the heart is more to the left side. It reduces that magnification as much as possible. That's why it's done left. What do I see on the lateral that I don't see on my PA? My right ventricle. My right ventricle. Now I can see it. Why? Because it's not behind the spine anymore. It's not hiding. Here, and I know it's technically in front of the spine, but because the spine is more dense, it projects forward. That's why we see the spine so well. It's way more dense, way more radiopaque than that ventricle, which is why we can't see it, because we see the spine more than the heart muscle. But here on the lateral, I've separated them out and got my side view, so now I can see my beautiful right ventricle right there. Okay? Sternum, nice side view of the sternum there. right? Sure, it kind of labels the left ventricle, the left atrium. I will tell you right now, if you're trying to evaluate your left atrium or your left ventricle, use your PA. They are not always easily visible on the lateral. They are not always easy to see. When it comes to the heart, I'm looking at my right ventricle on the lateral. I'm looking at all the other parts based off of my PA. You can see your costophrenic angles here. We'll talk about those more a little bit later as we go on. They're not exactly together. That means the patient maybe isn't perfectly lateral a little bit, right? They haven't rotated them just a little bit to kind of try to superimpose those, kind of the way they have to do with the knee, right? Because again, one lung, the costophrenic angle is farther away from the film than the other, so it projects it just a little bit bigger. So they got to try to adjust that, but it is common to have these guys just kind of a little bit off down here. That is normal. What else on this one? Scapula, humerus up here. Really the biggest piece of this guy, we're going to learn what to look at here. See all these like stripy lines? Those are all your ribs coming down and across. These are all your ribs coming down and across. Lateral is mostly used to look for what's called hidden spaces on the PA. We'll talk about those later. Those things that we can't see because of what's going on here from an anatomy standpoint. All right? But most of your evaluation is going to be from a PA chest x-ray or an AP chest x-ray. Your lateral is usually used in adjunct with it to help you pinpoint stuff and figure things out. It is unlikely you will get just a lateral chest x-ray on an exam because in real clinic, you almost never just get a lateral chest x-ray. You may just get a PA because sometimes in clinic that's all you get because that's all you order and that's all you want. Okay. What are issues with chest x-rays? So look at all this stuff we got going on here, right? There's a lot of stuff that we need to have happen to make sure it's adequate. In other words, I can make a diagnosis of, right? Because you think back to block 1, we did the MSK. I just needed to see soft tissue and bone, right? That was it. I basically had 2 densities of stuff. Sure, the medullary canal, a little bit less dense than the cortex, right? But really it's soft tissue and bone. Here I got soft tissue, I got bone in the ribs, I got lung tissue, I got heart tissue, which is thicker and more dense than the lung tissue, right? I got diaphragm area, I got trachea. There's a lot of different densities going on in the chest x-ray, which means there's a lot of different things we need to happen for us to be able to go, this is adequate enough for me to try to make a diagnosis on. So what are those things? So the first one, penetration, inspiratory effort, rotation, magnification, angulation. We're going to talk about each of these. Okay, this is like your intro slide. The intro slide of what am I looking for to verify that it's appropriately exposed, that it's a good x-ray. Okay? We're also going to talk about the position of the patient a little bit, inspiration, which goes along with inspiratory effort, exposure, and rotation, which goes along with rotation here. So it's just another way for you to take a look at these things and go, this is what I'm assessing. Look at the position, the inspiration, exposure, and rotation based off of these things right here. And we're going to go through each of them. So much like the bones, you need an approach. It's a little bit different, right? Here's the catch on this when you're doing a chest x-ray. What can't you ignore? The bones that you already learned how to look at, right? It's on the film, you have to look at it just to make sure you're not missing anything. But that falls in the bony framework. So the things you need to check on a chest x-ray. Look at the soft tissue in the bony framework, the stuff we already learned about how to do last block. Still got to look at all that. More so important is the soft tissue on this because it'll clue you into some injuries or some abnormalities that we will talk about. Next, I'm going to look at the diaphragm to make sure it's positioned the way it's supposed to be on both sides. I'm going to look at my pleura and lung fields, kind of go together. I'm going to look at my hyla. We'll see what those are and we'll look at those. Then my airway and my cardiac silhouette, because that's really what it is. It's the shadow of the heart. Develop yourself a systematic approach. I'm going to give you mine. You do not have to use it as long as you find everything. Simple man, Simple things. I learned the alphabet in kindergarten, probably a lot later than some of you did. I'm a slow guy, right? So I use the alphabet, A through I. So A is my airway, it's the first thing I assess. B is my bones, and I throw soft tissue in there because I learned that together last block, so I'm going to do both of those together. C is then my cardiac silhouette. D is my diaphragm. E is my effusions or extrathoracic soft tissue. We'll talk about effusions when we get there, and you will see what I mean by looking for effusions, okay? F is my lung fields, fissures and foreign bodies. Sometimes it's hard to see fissures on x-rays, but when you can see them, it can lead you towards an abnormality. You will see that when we get there. And foreign bodies, goes without saying, is things that are there that are not supposed to be there. Commonly like coins or magnets, because kids don't know how to keep things out of their dang mouth. Then I'll go into my great vessels and gastric bubble for G. Great vessels, I mean the aorta, the pulmonary vasculature, all that stuff at the top of the heart. Those are my great vessels. Then I'll go into my hyla and mediastinum, because the hyla are within the mediastinum, so that's why those are together. And then last but not least, my impression. What is your read? What is your impression of the film? After you've looked at everything, what do you think is going on? There's the Radiopedia link that talks about it. Like I said, simple man, I use this to learn this, because I did not come up with it. I just liked it because it was A, B, C, D, E, F, G, I. H. See, I couldn't say H. E, H, I. Yeah, this is hard to do together. All right. Here it is in a lot of words. For those who like words and want to read things and be able to refer back to it. I am not going to read all this because I basically just said it in shorter terms. Don't worry so much about the diagnoses until after you learn the diagnoses. I have them here, so that way once you learn how to find them, you can go back to this and go, all right, that makes sense. I would find that during this part of my process of reading the x-ray. Right? I would expect to see pleural effusions when I look for effusions. But more importantly, when I'm looking for, where's my fissures here? Pneumothorax, I might see it when I'm looking at the lung fields. I might see it when I'm looking at the diaphragm, depending if it's a tension pneumothorax, and we'll talk about all of these things. All of these things in blue we're going to talk about more. Okay? But it's meant to show you, what does this mean? How can I refer back to it? So I know it's busy, but. Okay. Take a minute, kind of absorb all of that. We'll break this down just a little bit more in a second. Lots of writing, so sometimes it's kind of hard to see it. But these are your reference slides, right? So the little guys down here are your spinous processes. This is the bony stuff. Spinous processes. Your clavicles coming across. We've learned that in the last block. Here's where I was telling you it's a lot easier without the lines. Aortic knob, pulmonary vasculature, left atrium, left ventricle. Aortic knob, pulmonary vasculature. It says arteries, but really it's just the pulmonary vessels, right? Because as we know from A and P, those pulmonary arteries and pulmonary veins, they all kind of sit with one another and go together, right? So I know it says artery on this side, but it's just the pulmonary vasculature, right? And then, I'm going to do that side. Left atrium, left ventricle. I have right ventricle labeled here, not because you can see it, but just so you understand where it's actually at. The spine is really what's projected, so that way you remember that the right atrium is this soft tissue coming on this side of the spine right here. Here's your right atrium, right over here. Okay? Your carina, that is the bifurcation of your trachea going into your bronchi. If you follow your trachea down, you split into your right and left main bronchus right at the carina. Follow the trachea down, we split right and left, right at the carina. Okay? Your right hilum, right here. So what is the hilum? The hilum is an area where your vasculature and your nerve bundles kind of come together through the lungs. So if I have a bundle of vessels or vasculature that's filled with what? Vasculature, blood, right? Fluid. Nerves, also soft tissue, right? That's why it's more radio opaque right in this area, because it's a bundle of those. We have a bunch together, all right over here, my right hilum. The left one sometimes gets hidden by the left atrium and the pulmonary vasculature, sometimes it's not, it just all depends. But that's where your hilum are at. They're in this general region, just outside of the spine, in that area. Okay? We will go over ribs ad nauseam, because you need to know which ribs you're looking at. But for right now, the yellow numbers are your posterior ribs. Boy, those look like they're right up front. They're not. Your blue numbers are your anterior ribs. Okay? When we get to the rib section, we'll explain why they look that way and how you can count them. Because that's important. Because one of the things we talked about was inspiration. It's not a good chest x-ray unless the patient has taken a big enough breath in to fill their lungs up as much as possible, because I'm trying to evaluate their lungs. And if I can't see all of their lungs, then it's worthless. So how do I know it's good? Well, we have a certain minimum number of ribs we expect to see posteriorly to determine it's good. Spoiler alert, that number is 8. Okay? We like to see 10 if we can, but minimum is 8. And we'll talk about how to count those when we get to the rib section here a little bit later today. This one takes practice. But if you understand when we talk about it, how your anatomy works with the ribs and how they come across, then you'll understand why it looks this way, and it should be a little bit easier to count, hopefully. Diaphragm, we already looked at. Costophrenic angle down here should be nice and sharp and point, not blunted, which these are sharp and pointy. When we get to those disorders, we'll see that. Here is that CT I was telling you about. So now look here. I got my spine, I got my right atrium, and how it bulges out on this side of the spine, right, which is why I can see it. And even the part of my right ventricle is on this side. Look, it's lined right up with left ventricle stuff too. Like, it's too hard to make out, which is why we can't see that right ventricle on a PA x-ray. But here's where my atrium lies, and I can see this bulging out right here. There's nothing stopping it from being seen. That's what this is. So what part of the heart is this? Right atrium. So if you had a question that said, what part of the heart, or what part of the anatomy is this? And a big arrow pointing to it, you're not going to pick right ventricle. Pick right atrium. Again, haven't made this test just like the last one. I'm not going to make it till like a week out. So probably nobody can accuse me of teaching you guys to the test. I don't even know. Okay. Lungs and heart. Easiest slide of the whole block. Right? But you can go back to this one to practice counting ribs, to practice seeing what normal looks like, to practice kind of looking at the diaphragm a little bit, looking at the clavicles, finding the carina, right? It's a simple x-ray that just labels the heart and the lungs, but it's going to allow you to kind of run through some of your systematic processes as we start learning some of these abnormalities. So definitely make yourself a note of lecture deck 1, slide 19, so that way if you're like, where was that thing? You can just get right back to it, right? It will help you out tremendously when you're trying to compare it to abnormal stuff. Okay, so what is penetration or exposure? It's how much radiation we give somebody, right? As we saw in the last block, if you give too little or you give too much, you can burn something out, or you might not be able to see it well, right? We saw that with some of these soft tissues, you couldn't see it that well, and I was like, well, you can see the bones, so you just go with it, right? The problem with a chest x-ray is if we burn out the lung tissue, it's completely worthless to us. You can't evaluate lung tissue if it's all black. Same flip side. If they don't give enough radiation and everything's all white, I can't evaluate everything because I don't have the appropriate amount of radiation. So we're going to talk about those and take a look and see what those look like for the overexposure and the underexposure, and how you can notify and look at it and go, that's not right, right? I need you to get another one, x-ray person. Go do it again, right? Politely, nicely, don't be a jerk, right? Good, sometimes Because sometimes they're like, that was the third one I did. It's the best we got right now because they're in a bed, they're unconscious. I did the best we could. It's the highest technique we have. It is what it is. Okay, cool. That's not their fault, right? But give them a chance to have that conversation with you. Biggest thing is for normal proper exposure, and we'll look at some of these, we should see the pulmonary vasculature. We're going to talk about that. We haven't annotated it yet, right? I haven't had that labeled yet because it's everywhere. I'm going to show you. And then we should be able to see the thoracic vertebrae and heavy diaphragm behind the cardiac silhouette. I should be able to make out those vertebrae even though the heart is hiding it, or it's kind of right in front of it. It should penetrate through the heart to be able to see those thoracic vertebrae. So here's an example of overexposed and underexposed. The overexposed speaks for itself, right? I got two giant black lungs. That's overexposed. That is worthless. What I want you to look at with the underexposed compared to, if you have it available to you, slide 19. Actually, you can go to slide 19 now if you want, and then use this up on the screen, right? Look at your spine. I can't make out any of my thoracic vertebrae at all. I don't know where they're at. I can't see the bodies. That's underexposed, okay? That's underexposed. Overexposed, I can make it out here. It's hard, I can make it out a little bit here, but I can't see any of my lung fields. How do I know that? All of these little grayish lines right here that are kind of splattered all over the place, like a spider web within the lung tissue, that's that pulmonary vasculature. Those are your vessels carrying blood to the different areas of the lungs, either to get oxygen or returning the blood that have been oxygenated, and they're more radio opaque because the rest of the surrounding tissue is air, so we can see that vasculature really, really well in the lower third of the x-ray, right? I don't see that here. That's what makes it overexposed. Why do I say that? Because sometimes you'll get just a really dark black spot here, but all this will come out, or vice versa. If you can't see that vasculature, it's over. It does not have to look as extreme as this, right? I need to be able to see all the lung field. So when I go back to slide 19, look at my pretty little grayish lines all over the place here, right? From like my bottom, really half to third down. Look at my pretty little grayish lines. I can see those all over. I don't see a whole lot up here in the apices, right? In the upper 1/3, and that's good. We'll talk about that. We shouldn't see it because all these are done for the most part with the patient standing. So what does that mean? What else is working with us? Gravity, right? So it's really hard for that to be still full. Right? There are still vessels up there, but they're not as full because it just pushes it up and they fall down. Pushes it up and they fall down, right? Whereas these guys aren't necessarily working against gravity, they're working with gravity. They're going down and out. So these are more prominent going down here. There's not a whole lot up here. That's okay. I'm looking down here. On top of that, look at my spine. I can make out each of the vertebrae. I'm not asking you to count them, but I'm just telling you that I can make out each of the vertebrae on the thoracic. That tells me it's properly exposed. I have my pulmonary vasculature with my vertebral bodies. This is a good x-ray versus those. Questions on that so far? Okay. Now, we want to make sure they breathed in, really English, that they took a deep enough breath in and that it's adequate. Like we talked about, minimum 8, okay? Minimum 8 of the posterior ribs. 10 is ideal, but I want at least 8. By doing that, I've expanded the lungs enough to be confident that my diaphragm or other parts are not squishing the heart, making things look larger than normal. Right? Because when I breathe in, my diaphragm goes down, therefore not putting any pressure on my mediastinum. When I breathe out, diaphragm comes up, it's putting some pressure on the mediastinum in the heart, which can cause it to smush a little bit, maybe look a little larger than it needs to. I can't see all my lung fields, so I want that big deep breath in of at least 8 ribs. Expiratory films, here's the info on that. If I give you an expiratory film, I'm going to tell you it's expiratory because they're so rare. So you're not going to have to determine the adequacy of an expiratory film in this course. because it's super rare. There's only 1 or 2 cases when you would possibly get it. So it's just more for your information there. I'm not going to make you pull that out. But inspiratory, you got to be able to know there's enough ribs in order to say that it's adequate. See how the inspiratory and the expiratory look different? Okay? I'm not going to make you tell me expiratory is adequate. Okay? If you see an expiratory film on the exam, it's there because it's needed to help you make the diagnosis, and it will be adequate. You won't have to determine that. But look at my inspiratory. So this is where rib number 8 is on both sides. We haven't started counting them yet. We will coming up. But I'm just showing you where both diaphragm is below rib 8 posteriorly. As far as inspiration goes, we're good to go. Once I get to number 8, and it's the whole rib, guys. Okay? Guys and gals, the whole rib. Not just here. Trace it all the way down to the edge of the thorax and make sure the diaphragm is below the entire rib. Here's a kiddo. We don't get hung up on cardiomegaly for the kids because look at how much different the heart looks. But what I use this slide for in particular, and you can do it with the adult too, look at my heart on my inspiratory. Look at how it looks in the same patient with my expiratory film. See how the heart shoots almost all the way out to the wall of the thorax? That's not because they necessarily have a large heart. It's because when they breathed out, when they blew all their breath out, that diaphragm came up. It's putting pressure up here and causing the heart to kind of squish out. Think of a water balloon. If I put pressure on the bottom of the water balloon, it comes out to the sides a little bit more. That's what happens with expiratory films. That's why it's so important on most of our films when we do our inspiratory that we get the diaphragm below rib 8 so we don't end up with what I call the water balloon effect. There's what it looks like in pediatrics. It does the same concept. Right? I know the images are crappy. This is just meant to show inspiration and expiration. Other than that, I can't diagnose anything off of this name. Rib counting. Okay. The ribs that come horizontal are your posterior ribs. Let's think about why for a second. Your ribs that are horizontal are posterior ribs. How am I doing my x-ray? I'm doing it facing this way. Posteriorly, my ribs are very horizontal right now. So when the x-rays hit, you're getting the horizontal part. The main meat of this rib is what's coming more horizontal. I know it goes down a little bit, but it's more horizontal, right? That's what's projecting there, because it's right here. My anterior ribs, when they hit, curve around, right? They're curving and coming up into the sternum, right? It's not this nice kind of horizontal, slightly downward shape. They're curving around and coming up towards the sternum. So when we get to the anterior, that's why they have this sharp downward projection, because of the way they curve around and come into the sternum. Whereas they're nice and flat and horizontal back here. That's why these are our posterior ribs. Now, how do we count them? Be very, very careful. Okay? Look at 1 and 2. 1 and 2 are almost directly on top of one another. It is very easy to count number 2 as number 1 when you're counting your posterior ribs. I, again, am a simple man. So I am going to teach you a simple way to count your posterior ribs so you don't get confused, hopefully. Hopefully. But that relies on learning how to count your anterior ribs first. So I'm going to go back to posterior in a second. Do you see the steep downward curvature of each of the anterior ribs? Okay, I've got them highlighted because of that concept, because of that anatomy, and the way it's curving around and getting projected. Steep downward when I'm counting them. Okay? You see that? Okay. Now that we see that, we're understanding that those are the ones. I'm going to go back to my posterior ribs. How do I count my posterior ribs? I start with anterior. Because look at how far apart 1 and 2 are anteriorly. It's all the same rib. They're all connected. The reason it looks like in 2 different spots is because of how the thorax curves. right? But because 1 and 2 stand out, not on top of one another, I start there. And so I go, okay, where's my first one? Oh, here's my first steep anterior rib. Here's my first steep anterior rib. Here's number 2. Here's number 2. I'm going to trace number 2 up, and boom, it's right there. So that's 2, and I count down. If you want to go even further, you can go 1, 2. Here's number 3 back in here. If I follow that up and curve it, it curves right into number 3. You see what I'm tracing? Let me do it on this side. Okay. Here's number 1, anterior. Here's number 2, anterior. Here's number 3, anterior. When I trace that up and over, that's number 3, posterior. So I'll go 1 and 2, trace this up and go, okay, there's number 2, and then start counting my posterior down. So because the anterior stands out more, that's where I start counting. If I need to count posterior ribs, let's say I see a fracture on posterior rib number 7. Oh, no, which one is that one? Hold on. Let me count. Go, okay, so 1, 2. Okay, so I know that's 2. So then trace that up. So then that's 2. And then 3, 4, 5, 6, 7. So I use my anterior to get me to start off my posterior so I don't get confused on if this is 1 or 2 ribs up here. Because depending on the patient, those suckers can overlap by quite a bit. So if you remember the shapes of what the ribs are supposed to be, and then try to use your anterior to start you off to make sure you're starting off at a good number, you can count down in that way. Right? Now, we draw your attention to one other thing, and then we'll go on a break. Okay? Notice where anterior rib 7 is. 1, 2, 3, 4, 5, 6. Anterior rib 6 is almost with like posterior 9 though, 9 and 10. 1, 2, 3, 4, 5, 6. Right? They don't line up with each other when counting down because the anteriors project more, and then on top of that, when you get to a certain number, what happens in those ribs? They stop like right here and turn to cartilage and come up, right? We can't see cartilage that well on x-ray. Cartilage isn't seen well on x-ray, which is why we do MRIs for like your meniscus, soft tissue. There's cartilage in the knee, there's cartilage in the labrum and in the shoulder joint. You can't really see cartilage. So part of the reason you have less anterior ribs on the x-ray is one with the projection, and then as you get further down, they turn into more cartilage. There's still ribs up here, but then they shift more. All of this is cartilage down here in like your 9 through 12. That then comes up into more cartilage up into the sternum. It's like right about here. Their costochondral space. We'll talk about that later with costochondritis. So don't do the mistake of 1, 2, 3, 4. Okay, so 5. So this must be 5 posterior rib, right? You gotta trace it back. And I would say the best way to trace it back is once you find number 2, trace it back. You go, those are 1 and 2, great. Now 3, 4, 5, 6, 7. What does that mean? I'm not giving you a rib fracture in 1 and 2 posteriorly. I might give you one down here. I might just say, name this rib. Anterior, posterior, what number, right? So practice through that, get an understanding of what's the best way. If you're still confused on that, please let me know. I will help you count them. I will help you learn how to see them because I know how confusing that can get. All right, let's stop there, take a 10-minute break, come back to the top of the hour. Anybody like NFL fans in here? Yeah, no? Did you actually see watch the game at all last night? Or were studying for last night? Yeah. Actually, I don't want to watch preseason either, but it's officially starting. The NFL season is right around the corner, finally.
First quarter.
We have football every single week until February. This is great. My kids hate it. What's that? College football too, right, but that takes a little bit longer to get started. And I also prefer college football, but if we wait for them to start, then we can't get excited. We can get excited now. Because NFL starting means college football is right around the corner. Not that it matters because Michigan's going to win this year, so don't even bother watching. Hey, we got the number 1 quarterbacks prospected in the country, so. Stolen from LSU.
Not gonna help you this year.
Hey.
Arch Manning's
Oh, this will be fun. I wish I had you guys next semester. Anyways, I'll come check in on you. Had a good question on break. I always break. Somebody asks me every single time that I teach this course, and I always wait till someone asks it before I bring it up. Does anybody know what sinus inversus is? That is a condition that a patient will have where everything in their body is flipped. Right? So their heart is flipped. Their liver and spleen is flipped. Everything is flipped. No, I am not going to give you a sinus inversus patient and try to trick you on the exam. I won't even give you one and tell you it's a sinus inversus patient, right? That is so rare, right? So how would you tell if it was that? Because here's what's going to happen. The radiology people are going to flip your x-ray the way it's supposed to look, even though they have sinus inversus. So how the heck would I know? Easy. They're going to flip it the way it's supposed to look, and your left marker is going to be on the side with that little itty bitty right atrium, because everything's the opposite. But you won't have to worry about that, because this isn't something that magically gets found, like later in life. Usually they go to doctor's appointments with their kids. They get well visits. This gets found early. So you already have a medical history and a medical card that will tell you that the patient has sinus inversus. And I promise you those patients, or at least those patients should, were told that they have that, and told to tell people, hey, I'm going to order a chest x-ray. Oh, hey, just in case you weren't tracking, I have a condition called sinus inversus. They're told to do that. Now, whether or not they do, right? It's like G6PD patients. Like they're like counsel, like you better stay, and this is what you usually get. Do you have any past medical conditions? I don't know. I got something called G6PD. Well, you don't have that. It's a deficiency of that, right? That's not the disease. But at least you knew enough to tell me those 4 characters, G6, P, and D, right? Same thing with sinus inversus. They will tell that. So no, I'm not going to throw that at you. I'm not going to give it to you and even tell you it's sinus inversus, but it is a possibility, right? All right. Let's get back into our evaluating whether or not an x-ray is quality. Rotation. We briefly talked about rotation in the last block, so we'll just kind of quickly cover it again as a refresher, right? There are 2 areas you look for rotation, so we want an x-ray to be nice and flat like this, but what happens if the patient just turned, right? How do I know that? So we're briefly going to talk about it. You can look at the spinous processes, or primarily what I like to use is the sternoclavicular joints. The clavicle lining up with the manubrium in that sternum. Okay? This is a little bit of an image versus AP and PA telling you which way they're rotated. I don't care. I'm not going to ask you to tell me which way they're rotated. I need you to be able to point out that the patient was rotated or not rotated. Don't care what direction. This just gives that kind of radiological shadowing of why it happens the way it happens for those who like to have that deeper understanding. I'm not going to ask you whether left or right rotated. Don't care. Okay. The first picture is how things are supposed to look. The one on the far left. I have my spinous processes coming down and my clavicle ends meeting up with my manubrium and my sternum. Right here. Spinous processes, nice and straight little line in the center of the trachea, right, which is really the spine, but the trachea is right there, so we can see them very nicely. And the clavicle ends come right up against my manubrium and onto my sternum. Now my next 2 below pictures are the abnormalities, right? Can't really make out my spinous processes, but look at where my clavicle end is, and look at where the other one is. I have one with this huge gap. Is that dislocated? I don't know, maybe. That's kind of tough to dislocate your SC joint, but it can happen. But I'm going to suspect no, because the other clavicle is also more medially and into the spine than it should be. That clavicle is not being shoved into that area, right? They're not both dislocated. Now, if I had this gap and a normal clavicle on the other side, then maybe. But I'm telling you, dislocating your sternoclavicular joint like right in here is so difficult to do. Right? So difficult that we don't even have it as an abnormality. Right? So if you see this, it's rotated. Okay? I have this nice little animation here of another one, kind of showing you as it rolls through, tracing out the trachea, the carina, the spinous processes, and the edges of the clavicles. Okay? Just like in the first block we briefly covered it, this is your sign for rotation or not. This is where you look. It's the only place you really need to look. Why is this important? Well, if I'm rotated one way or the other, it may appear to have a larger or smaller heart in certain areas. It might look like a huge right atrium, because when I rotate, more of the right atrium is now being projected out. Or left ventricle, more of the left ventricle is being projected out. It can throw off your whole mediastinum of evaluation if you are rotated too much, which is why this is one of the things you have to make sure, okay, it looks like everything is good. That's why it's one of the techniques of an adequate x-ray. Magnification. Questions on magnification? Okay, it's there. If you have questions, let me know. AP versus PA is going to be the biggest thing on this one. And I already told you, I will tell you if I'm giving you an AP x-ray. There's your pretty shadow puppet picture to help understand magnification. If anybody can do this, let me know. I would love to record it. Because that would be impressive to show everybody. Preferably if you can make the bird fly away. All right. Here's your PA AP chest again, repeating the magnification stuff. Okay. FYI slide only. This is breaking down, really, I know that it's a little underexposed, but really kind of breaking down the differences here in words of the AP versus the PA. What is FYI? This chart here, guys, I don't care about all this. I'm not testing you on it, but it could help you understand the AP versus the PA. Again, I will tell you if it's an AP or a PA. But this will help you understand why it happens the way it happens. Angulation. Somebody asked me this on the break. Are we shooting the x-rays? Which way is the x-ray pointing? So for a chest x-ray, it's a horizontal beam, straight at the patient. There is no angulation of the beam. However, sometimes we will do it on purpose. Because if I go back into my normal chest x-ray, what do I have here in the way of some lung tissue? Clavicles, right? Clavicles and ribs. I can't really make out this lung tissue that well. What type of disease process, I think you covered in the pathology? Tuberculosis, right? So if I have a patient who I'm concerned with tuberculosis, do you think I'm comfortable looking for any type of cavitary lesions with these clavicles and ribs in the way? If I want to be confident that I'm not seeing anything, probably not. So I'm going to get something called an apical view, where one of two things can happen. The patient can lean back, or in reality, in today's day and age, we just angle the tube up. It's a lot easier, right? But back before we had that, lean back, right? And so what it's going to do is it projects those clavicles above the lung field, because I'm aiming upwards. It's a shadow, right? If you take that shadow and aim this way, it projects things higher. It's like the bat signal in the sky, right? When you aim it that way, it goes higher. It goes out there. It gets bigger. So here's your normal chest x-ray. And then when I do my apical view, look what it does to my clavicles. It projects them up, and now I can see those apices really, really well. Now I'm confident this patient doesn't have a tuberculosis. Okay? Why do I teach this to you? You will never have, no, let's say never. I don't like to use never. You will rarely have angulation as a bad film because it was accidentally angulated. Maybe in those APs a little bit, but listen, if we're doing an AP chest x-ray, what did I tell you? The patient is bedridden, right? So we're just going to get the best that we can anyways. There's not a whole lot we can do about that sometimes. But you may want to order something like this to make sure, specifically in the evaluation of tuberculosis or any other apical lung disorders you end up learning about. Okay? Now, if they were just coming in and I didn't have any symptoms, right, and they had been to a tuberculosis area, I'd be okay with that PA. But if they're coming in coughing up blood or like have fevers and then that's a risk, no, I'm getting this. I want to make sure. Because the last thing I need is him on an HED coughing all over the produce. They do it. Right? What do we go over? Penetration, inspiration, rotation, magnification, angulation. Those are the 5 things you got to look at to make sure it's adequate. We already learned how to count the ribs. Here's a rehash of how to count some ribs. Other things to help you out. The posterior ribs do appear more prominent on the frontal PA chest x-ray, frontal versus side view or lateral. Oriented more or less horizontally, a little bit of downward at the end, like, to kind of show the way the shape of the rib goes. But the biggest thing a lot of it too is each one of those guys attaches to a thoracic vertebral body. Every single one of the ribs, 1 through 12, it attaches posteriorly to your vertebrae. So that's another way you can make sure you're counting them appropriately. You're counting posterior ribs. Does it attach to the vertebrae? If it does, that's where you're going. Anterior is less prominent, oriented towards the feet, that downward motion. They attach to the sternum, and then that's when you get to that cartilage. It's typically not visible until later in life, right? That's going to be like your grandma, your grandpa. Why? Not because the cartilage has gotten more, visible just because they're older. It's actually starting to calcify, right? Bless you. Again, third time is just attention. Okay, all right. Third time you're looking for it. All right, let's make it sure. Okay. Good too. So when they get older, right, the ribs will start to calcify just because of old age, and so you may see them on an x-ray, but that's the only time you're really going to see the cartilage of the ribs. So now what this is this is a CT over here that was reconstructed. Remember how we saw some of those in the first block, where it took like that knee CT and kind of like reconstructed it so it looked like a 3D model of the knee? That's what this is, to show you where that cartilage starts, right? This is all just looking at bone. So no, they didn't like break their rib cage open here, right? That's the cartilage. That's why we can't see that on the x-ray, because it's not there. The CT, and when we pick it up and they do it, they're like, hey, do a 3D model of just the bone. And you can tell the machine to do that, and it does that, and it leaves the cartilage out, right? So that's kind of going to show the different ribs and why the cartilage does what it does. And look at these posterior guys. All of them go directly into the vertebrae. Okay? The anteriors kind of come down and stop. See how it stops like mid-chest right there? See how that rib kind of stops? Like, oh, it just kind of stops, right? It's because of the cartilage. Yes, sir?
Just out of curiosity, how frequently are these reconstructions?
These, rarely.
Rarely?
It's just a really cool picture to explain the cartilage, so I threw it down there.
This is like more like intensive surgery they requested.
Yeah, so ortho will do it sometimes, right? Ortho will do it sometimes, primarily to really look at like those nasty fractures. But something like this with the rib cage, like it's almost never done. But it doesn't, so what you'll see in medicine sometimes, like, well, how do we get this? Well, easy. This is after the patient got a scan done. This doesn't harm the patient at all. It's not an extra scan. It's just done with the data. It's already there. So somebody was probably toying around with the 3D remodeling thing. It was like, hey, look at this cool thing I got in the chest, and it got published out there. So, but very rarely are these really useful, except for maybe in very specific, maybe orthopedic surgical examples, but it doesn't get done very often. Here's a lateral view of the chest. You notice how, on the lateral, I didn't once talk about whether or not this is an anterior or posterior rib or how to count any of it, right? Right. Mainly because I don't know where these ribs are up here. There's too much other stuff hidden, like shoulder and soft tissue. Shoulder and soft tissue. And this is just the axillary portion of your rib. So this is the side of each rib. If you wanted to know what part of the rib is fractured, if you see one here, you would go back to your AP or PA, try to find it in the general facility, look for your fracture or vicinity, look for your fracture, do your counting, figure out its right rib, posterior number 5, or whatever it ends up being. This is why we do 2 views on the chest. Perspective is important, right? You think you see something, but then you realize you don't see the whole picture, okay? You don't see the whole picture. So there are areas on a lateral chest x-ray that we specifically need to look at because we can't see them on the PA or the AP. Here's your 5 areas. Listed right there by bullet point. Okay? The lateral is used to address the shortcomings of the PA film, which is why I said you will almost always get a PA film. You will almost never get just a lateral film, because the lateral is just designed to give you the stuff that you can't see on the PA or need to further delineate which lobe something is in or something along those lines. The lateral by itself is not necessarily useless, but not very useful. Okay? Here's a nice little chart which kind of breaks down the regions that we're going to look for and look at, right? And what you should see on your lateral chest x-ray in words. Because I'll have pictures and we'll break it down and we'll look at the pictures, but sometimes it's nice to refer back to a chart that has words that paints that picture for you. All right? Right hemidiaphragm, slightly larger than left, or slightly higher than left, and we'll talk about that. Okay. The areas circled here are the areas that are the blind spots on the PA x-ray. I can't see behind the sternum because the sternum's there and it's bone and it's taking up all my radiation. What's going on behind the sternum? I don't know. I can't make it out. I can't see behind the heart because the heart's sitting right here and it's taking up all my radiation. So on a frontal view or PA view, I can't see anything behind the heart. I have no idea what's going on. I can't see necessarily behind the hilar region because that's a big vascular bundle, right? So it's taking up a lot of that radiation. So what's behind it? I don't know. It absorbed it all. I can't see the posterior hemidiaphragms. These are the anterior hemidiaphragms, costophrenic angles, and I'll show you that on the lateral x-ray. So because we can't see those areas, we get the lateral chest x-ray to find them all. So now, when I look behind the sternum, I can see my lung tissue and I can make it out. This should be a nice little darker area right here behind the sternum. That's my retrosternal space. I can see it now from the side. I couldn't see it before. Behind the heart, my retrocardiac view in the red circle. And if you notice, the colors here line up with the colors there. If you're colorblind, I'm sorry. Retrocardiac space right behind the heart should be darker. Why should it be darker? Well, because the radiation's taking all this. There's nothing here. There's air compared to a bunch of tissue and bone and everything. It's going to look a little darker. That's normal, right? So now I have my hilar region behind my hilums right in here. Okay, right in here. I can now see all that where I couldn't before. If I go thoracic area in the center, I don't have a color on here, right? Because you can see the spine. This allows me a much better visualization of those thoracic vertebrae too. Right? I can really see each of them, whereas I kind of make them out on that frontal view, on that PA view, but not in the detail that I'm getting right here. And then my costophrenic angles. I can see my posterior. What you're seeing on the PA is the anterior up here. This is what we're seeing on this film. These are your anterior costophrenic angles. Why? Well, because when I'm shooting the x-rays from the back, right, and I'm hitting where these posterior costophrenic angles are, where lung tissue is, look at what's penetrating after this. All this stomach and soft tissue and organs and liver, it's absorbing all that radiation, right? X-rays come in from here, they hit here, great, there's air, but now I'm absorbing it all. So by the time we get to here, I just have soft tissue projecting. Because it went through those lungs and then went through all that soft tissue and took it all up. None of that had really hit the film. So that's why you can't see the posterior costophrenic angles on the PA or the AP. because these are the ones I can see. These ones I cannot by the time I penetrate. So we need the lateral chest X-ray to see those posterior costophrenic angles. And because it's a left lateral and magnification and projection, my right diaphragm, hemidiaphragm, is farther away from the film. That's why it's a little bit higher, because it's slightly magnified compared to where the left one is on the lateral, right? Because left's up against the film, so it hits right first. It projects it a little bit more. Not to be confused with the PA. It's because of the liver, not because of the magnification, right? Biggest thing I want you to know from both of them is the right hemidiaphragm is supposed to be slightly higher than the left. That is not abnormal. They should not be in the exact same spot. That is not abnormal. Okay? Questions on that? Questions on my lateral chest X-ray? Okay. Heart and great vessels. Yes, yes.
It says on the lower chest X-ray here for fissures of the lobes there. Is that something we've got on there as well, or is that something we're doing?
We will look at fissures a little bit later. Fissures by themselves, the Cliff Note version of this is, yes, fissures can sometimes be seen on X-ray if you look really closely, and sometimes you can see them more on the lateral than you can on the PA, and we'll find some of those. In reality, we'll find the fissures more when we find some abnormalities, and the fissures will stand out. Thank you for clarifying. But technically, because of the way the lobe's set up and overlap, a lot of those fissures on the PA can't be seen, but might be able to be seen on the lateral. Yeah, but I won't make you pull that out unless it's in relationship to an abnormality. Okay. Vocabulary, hemithorax, half of the thorax. Costophrenic, we talked about the costophrenic angles. It's involving ribs and diaphragm, kind of where that comes down to at the end. And cephalization. Cephalize, cephalad, up towards the head, right? There's a specific thing called cephalization, which we're going to talk about. Normal cardiac anatomy, plain film, CT, MRI, a little bit. Abnormal cardiac appearance, cardiomegaly, congestive heart failure, and pneumopericardium. What color is air on X-ray? Black. What color is soft tissue and fluid? Grayish, right? And the same. Which is why the heart looks the same as, it's all one what's the word I'm looking for? Contrast, one density, right? Hey, look. Another annotated thing to know you're normal. This one takes it a step a little bit further. This one starts to show your superior vena cava coming up a little bit. Starts to show your aortic knob a little bit, but it breaks down how the heart looks and how the heart is structured with the valves and the chambers, right? So again, look where my right ventricle is. Hiding right down here, kind of projected into the belly a little bit, but behind the spine. But boy, that right atrium sticks out. Okay, left atrium, left ventricle. Wonderful. Okay, here's my aortic knob and root. Right up in here, that's that first bulge. Here's that bulge of that pulmonary vasculature. Then left atrium, then left ventricle. Aortic knob and root, pulmonary vasculature, atrium, vesicle. Boom, 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 boom. And then right atrium. So this one I like because you can kind of go back and forth. Yes, I agree. You cannot really see the brachiocephalic veins that well. You cannot really see the brachiocephalic artery that well, or any of those guys. Partially because, again, they're constantly squeezing blood out of them. Gravity, a little bit different. They don't really project. You really can't see a lot of the main arteries and veins, even for the pulmonary, outside of the bundle, kind of where they start before they branch out, because they're just so small in comparison. So the bronchioles, everybody, right? This is showing you why these lines, these white lines or grayish lines, all these white grayish lines, are not the bronchioles. They're the vasculature, because bronchioles are filled with what? Air. Air is black, so they're in here, but I can't make that out. But more commonly than not, if you have a bronchiole, you have a vessel. So when you're seeing all these vessels on here, there's bronchioles attached there too. You just can't see those because we can see the vessels, which are filled with blood and filled with fluid, and that's what actually stands out. That's why we say the lung markings, is the general term for them, is our vasculature. We know there's bronchioles there too. You just can't see them unless there's an abnormality. Lymphatics as well, yep. But I can't make out the difference between them because it's still a fluid-containing system. So yes, lymphatics as well, right? And so this is where it's saying that the bronchi are often invisible because they run parallel with the vasculature. So what you're seeing here and here is a couple of those cases where you might be able to make out bronchioles. Why? Because there's inflammation and fluid surrounding them, right? That's why they stand out. And here's a CT kind of showing you all the inflammation and fluid around the bronchioles, right here, that's what all those red arrows are, which might make it stand out more on the x-ray to where now instead of going, hey, those are vasculature, like, oh, look at the bronchioles, look at the airways, right? And so that's kind of some of those signs. You can see that. We will cover what's called parabronchial cuffing a little bit more. So don't necessarily, this is more of an introduction to it. And then you'll see what I'm talking about. They'll really stand out on some of those other x-rays. There's your normal one again. Lots of different normals for you guys to kind of refer back to and look at. And another one, so slide 51 is a non-labeled normal for you guys to kind of go back to and use for your heart and great vessels, okay? So let's go over this a little bit. Once again, right atrium, pulmonary vasculature, so aortic knob right here, pulmonary vasculature, left atrium, left ventricle, everything over here, boom, 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 boom. Another thing we're looking at, let's count some ribs, right? Do we have enough? Is this adequate for respiration? Well, if I go 1, 2, 3, 1, because if you look here, you see it come down, right? 2, 3, so that's 2, 3, 4, 5, 6, 7, 8, 9, 10. Beautiful. So 1, 2, come up, that's 2. So that means that's posterior 3, 4, 5, 6, 7, 8, 9, 10. We're good. All right, I got more data. I can stop at 8. I'm good to go. So we got that. Now I'm going to look at rotation. Okay? Spinous processes look pretty centered with that trachea. I'm happy with that. Right? I think it's okay. It's close. But I can clearly make out both sides of the clavicle. And the key thing, right? If I'm on the fence going, is it rotated? Is that clavicle separated? I'm not really sure. Go back to my spinous processes. Those look pretty centered. Those things move with one another. Right? So those are centered, so we're going to call that good. No rotation, no concern. Magnification, we haven't quite learned cardiomegaly yet, but I'll give you a little spoiler there. It should be less than half, the width of the heart should be less than half the width of the thorax. I don't need you to pull out a ruler, just eyeball it. Right? So heart's not magnified here. It is not more than half the width of the thorax. All right? We got that. Exposure. Let's talk about exposure. I can see my lung markings throughout on the bottom 2/3. I can make out each of the thoracic vertebrae going up. My exposure is good. So, and as you get better at this, you'll run through those 5 guys, the exposure, the inspiration, the magnification, the rotation, and say again? Penetration, thank you. You'll run through those, right? And in like 15, 30 seconds, right? Just like boom, 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 boom. Because once you know what you're supposed to see, it's what you're not supposed to see that pops out at you. Like, I can't see those thoracic vertebrae. I can't hear it. Like, that'll pop out at you, right? So we run through that, so we're good. And that's pretty much as far as we got as far as evaluated it, and just knowing that it's adequate. Here's another lateral one. Here's another lateral one. So now on this one. Can't count ribs on this one, right? Too difficult to count ribs. The biggest thing I would say for this one is when we talked about those hidden areas, how do they look? Do I have that darker retrosternal and retrocardiac space? If I do, and it's a little bit darker than like it's supposed to be, then I would consider that adequately penetrated, exposed, that kind of thing, because I should have a darker area. If they're jet black and I can't make out any of these lung markings, it might be too much, right? I should still see some of my lung markings, some of my vasculature down here in the retrocardiac space. If I can't make out my spine, outside of up here, like from like, I don't know, like right about here down on the scapula down, if I can't make out my vertebrae down here, that's probably underpenetrated.
So you would say, sir, that this is pretty normal, it's not.
This is adequate. Yeah, no, this is normal.
Okay.
There's nothing wrong with this one.
No, underexposure.
This is a great lateral chest x-ray. Yeah, this is what I would want you to base your normal off of when you're going through the stuff. Just running through the areas that I'm looking at to verify that it's normal. Now, what is the issue with doing x-ray when we're trying to evaluate the great vessels in the heart? We can't really see. I don't know what's going on the inside. What do I care about? I care about what's going on the inside. I mean, sure, maybe large, and I can notify that kind of stuff, but I need to be able to see what the heck's going on the inside. And this is when we jump to CTs and use contrast. This is all normal. We'll kind of briefly go over it, right? So, really just focus on the far right. I have my ascending aorta. I can't see the full aortic arch because of the slice I have. My descending aorta, full of contrast. Full of contrast. Got the heart here, full of contrast. Because before it goes into the aorta, it goes to the heart. Full of contrast. So we'll use that to further evaluate some of the vasculature or certain areas of the heart if we're concerned with that. There's different slices, different areas, right? If I expect you to pull out an anatomy piece on a slice of a CT, it will be one that is clear enough and not ambiguous like this middle one, right? Because like, well, I don't know, if I were to scroll up and down, then I might be able to trace something and figure out what is what body part, right? So, but if I'm going to give you one, it's going to be one that we're going to cover specifically. I will point out specifically and say, this is this, this is that. This is just to kind of show you why we do the CT scans and how you can see the trachea versus the esophagus. For the love of goo, look at the size of the trachea and look at the size of the esophagus on a CT. One's filled with air, one barely is. This is not the esophagus. How do you know that's going to be on this exam? But I will tell you, when I've done anatomy stuff in the past, the number of people that confuse the trachea with the esophagus is frequent. So don't do that. How do we know that's left lung versus right lung? It's the opposite, right? Remember, CT's opposite of the way you're looking at it. Okay. Here's a really good slice on the far left. And we'll get into that anatomy. We look at some of the abnormalities. That is really good at trying to pick some things out. Because I have AO is aorta, right? There's technically two pieces. Because you have an ascending and a descending, depending on where you're at. This here, this big thing here, this is your pulmonary artery. This is the pulmonary artery. Okay? S is the superior vena cava. But that pulmonary artery is extremely important because when we do these scans and when we get there, this is where you're looking to look for a pulmonary embolism. Primarily in the pulmonary artery. Why? Because I can deal with emboli down in here, little clots down in these little smaller vessels. See how they're branching out like little spider webs? These are all the blood vessels going out throughout the lungs, bringing blood to it. I can deal with small little clots in there. It's going to cause some pain, but that's not going to kill the patient. You get one in here that stops blood flow, it's night-night time. Maybe not initially, but if it's not caught and treated, and it blocks the whole area, right? So they have a pulmonary embolism that actually will be, and it goes through this branch and into this branch. It's called the saddle one. Another name for the saddle pulmonary embolism, the Widowmaker. Right? It got its name appropriately. So this is the main artery you're looking at when we're looking at those, and we will get to see some of those, what that abnormal looks like during this block. Alright. Here's your sagittal slice to kind of show you what it looks like, and your coronal slice to help you get an idea of the anatomy when you're scrolling through a CT. And what's key on this one, guys, I had to give contrast for you to sort through these things, right? Because when is CT? It's a form of X-ray. So if we didn't give contrast, there is no way we're sorting through where that left ventricle goes up to the aorta or where the right atrium is at. It would just be one big gray blob. Does that make sense? Alright. Anatomy is important. Excuse me. Oh, I didn't go this. What's this area here? It's just past the carina, correct. That's where the trachea is split into the right and left main bronchi. Just past the carina. Good. This one's FYI, okay? So this kind of shows that right main bronchus, left main bronchus. Boy, look at that right. Look at how superficial that, or superficial, how vertical that is. Okay? So, and right here, right and left main bronchus, it's showing those breakoffs. The solid white arrow right here is sometimes where you get those lymph nodes to appear. I'm not going to make you pull lymph nodes out on CT or X-ray. I'm not. There's no benefit for you guys learning how to do that. Okay? But sometimes you will see those lymph nodes in there. Okay, inflamed, angry, but FYI, upper right hand corner. It's small, but it's there. Not testing on this slide. Or this one. Right? Why am I not testing you on an MRI of the chest? I don't know anybody who's ever ordered one. Right? They're out there. They're probably very specialized specialists that do it for a reason. I'm sure cardiologists have done it. I'm sure other types of specialists have done it. But honestly, I'm not going to test you on an MRI of the chest because it's not beneficial to you guys mentally. It is rarely ever done. I don't know when you would even order it. So I can't even tell you this is when you would get it. I don't know. Practice chest x-ray for you. The idea behind this one is, can you in your mind's eye tell me where the right atrium is? That's what I want you to do. If you said here, or here, you're correct. This one in the note, it's a little tricky because we didn't cover it, but if you had to guess, could you pull out the trachea? What's that? Yes, I am sure it's not the esophagus. I am very sure. You guys may not be yet, but I am. Okay, that was our introduction of overall assessing the chest radiograph, right? And looking at the heart and great vessels. Okay? Not over yet, I'm sorry. It's not over yet, I'm sorry. Again, I'd much rather use this time and, if possible, give you time on the back end than have to get behind, and especially with us being at the end of the semester. Any questions on the heart and the great vessels, or what establishes a good chest x-ray? When you practice this, okay, what I would say is practice counting ribs, practice looking at stuff, use the ones I've given you, or use the annotated ones on Radiopedia. Okay, right now as far as Radiopedia goes, and it goes to chest x-rays, just do normal chest x-ray and normal chest x-ray annotated. Please, if you get ahead into some of this stuff and looking at it, do not start looking at those disease processes yet, because it is going to spiral you down a confusing rabbit hole because we haven't broken it down yet. So don't get ahead on that yet. But practice your normals, please. Okay. Airway, parenchymal, visceral, final, interstitial. Remember all these words? They sound familiar? I can tell you Mr. Rogerio, or I forget what the name of the A&P one guy is. Mr. Wright, that's it. I've talked a long time, I always forget his name. It's so easy. So bad at names, guys. I'm sorry. So bad at it. That's why I don't call my wife. I just say like honey or babe. That's what she hasn't known for years. I can name my kids 1, 2, and 3. No. All right. So these are your vocabs, right? To understand what's going on with the airway, what the anatomy is. All right. We're going to cover normal airway anatomy on a plain film and CT, and then look at all the disorders we are going to cover in this course. You, by the end of this block, with an X-ray and a patient vignette, are going to be able to come up with a most likely diagnosis with everything that you see based off of these things and more, but just at least this stuff. You will be able to, promise. Normal airway anatomy, we've already kind of covered some of that. The trachea going down into the bronchi. The biggest thing is the right bronchus is more vertical, which means we're at more risk of what in that bronchus? The foreign objects, aspiration, something, right? Say again? Yeah. Yep. And also, really easy when you're putting an NG or an OG tube in of going way too far and end up just inflating this lung because you accidentally went down here. That's why the chest x-rays are important to make sure. Just where you give them the air, you just see one side of the chest, right? Okay. All right, lobes. How many lobes in the right lung? 3. Color coded. Sorry, you didn't color mine. But look at the confusion on just the PA. Look at where the lobes start and end. They overlap significantly. This is another reason we need the lateral X-ray, is to help us break down the lobes. So for example, if I have a mass in this part of my PA chest X-ray, I have no idea based off of just that if that's middle lobe or lower lobe because they're overlapped. But when I get my lateral, if I see that same mass down in here or over in here, now I've pinpointed what lobe it's in. So you start with the PA and go, and when you see them, you will see what I'm talking about right now. We're just showing you where the lobes are, right? You start with the PA and go, that looks weird. What's going on there? What lobe is that in? I'm not sure, like a pneumonia or something like that. Then you use your lateral to compare it to go, aha, it's in this one. Same thing right here. If I had it right here, boy, I'll tell you on the PA, that sure looks like it should be upper lobe. But look how big that lower lobe is. It could be here and here. And that's a lower lobe pneumonia or a lower lobe abnormality. So you use them in conjunction with one another. Same thing on the left side. I don't know why they call it an upper lobe. It expands the whole dang chest. The same thing, but look how high the lower lobe goes on that PA. Significant overlap. So really, anything not in the tippy top, even the bottom questionable, right? The tippy top, you're like, I don't know what lobe it's in. You go to your lateral, there's a clear delineation between the two. Right? So just look at all those. We'll go over things in those areas and pinpoint those lobes as we go through it. All right. Here is another X-ray with more labels for you. Okay? The white, the grayish lines are your vasculature. Bronchi are invisible, run parallel with the vasculature. Okay? Kind of what I'm circling here is all the vasculature in there. This is not a mass. Well, it's not a lung mass. Those are breast shadows. Right? We have a female patient, that is to be expected. Do not let that throw you off. Sometimes people will look at that and, oh, I saw this line kind of come up, so I thought it was a rib fracture. Trace your breast shadows just like you trace your bones. Okay? See a theme in block 1. Or lecture 1. Okay. We've already covered all this, but here's another one for you. Left side against the film Y, we talked about it, right? Against the heart and the great vessels as close to the film as possible to decrease that magnification because all that's on the left-hand side. We get the lateral to help determine the location of the abnormality, confirm the presence of the disease, right? Demonstrate the presence of disease that's not visible on the PA, so find all those areas that we can't see, okay? Talks about the fissures again being visible, guys. Don't spend headaches looking at the fissures. When we get to the abnormalities, you'll see that fissure stand out. Like when there's fluid in a fissure, you'll be like, oh, well that makes sense. Like once I kind of show it to you. So for right now, don't get hung up with trying to find the fissures. However, if you're just kind of curious, like whereabouts are the fissures? This is why they're more visible on a lateral x-ray as opposed to the PA, right? Clear delineation line, I can't really make out where some of those fissures are. So sometimes they say you can see the minor fissure here on the PA because these two lobes, the middle lobe and the upper lobe, kind of meet like right there. So maybe you might be able to see it, but in reality it's the lateral x-ray that you can see the fissures well if you're actually looking for them. Don't bash your head up against the wall trying to find them yet. We will see them with the abnormalities. And sometimes with the x-rays. So now, right, if you look really closely, there's the minor fissure on that PA. This is one of the best images I can find that actually shows it prominently, right? Because even I will admit that is really hard to see. But look at the difference on the lateral. Look at my fissure on this one. And even on all of our laterals that you're looking at, you can't see this on every patient. But you can see how, at least when you compare it to the PA, it is more visible on the lateral because of the way those lobes sit. So here's another one showing you the lateral technology, but this one in particular, I want you to look at the thoracic spine. Do you notice anything about the upper thoracic vertebrae compared to the lower thoracic vertebrae? Spacing a little bit, but that would be that this space is more look at the vertebrae themselves. Width a little bit. But they should get bigger as they go down, right, because of the lumbar spine. Would you say that the more superior thoracic vertebrae look more radio-opaque than the ones below? Right? One of your signs of also exposure and penetration, which I saved for now, do the thoracic vertebrae get darker as you go down on your lateral chest film? They should. Now, why is that important? It's not just an exposure thing. But later on, when we get into like pneumonias or consolidations, if I have a large area of fluid sitting in this lower lobe of the lung, one of the signs of it being there might be the fact that all of a sudden these vertebrae are more radio-opaque than the ones above it because there's a layer of fluid laying over it in the lung, right? It's not here, but you'll see when we get there. But in order to understand that, you need to know first that they should get darker as they go down. Why? Less soft tissue, more lung as I come down. So they should be darker. Okay? Another normal airway anatomy x-ray for you guys to practice on. Here's your lateral talking about what I just talked about, right? In words from what I just said. Spine sign is what it's called when those vertebrae are more radio-opaque than they should be. Why? Because the sign is over the spine. So they were smart and they said it's what we call spine sign. I'll make this stuff up. I just know it and tell it to you, right? It doesn't always have to be a pneumonia. It can be anything that's sitting in that area of the lung that is making the vertebrae look a little bit brighter than they're supposed to. Okay, this won't take long, right? These slides here, go through, use them. It paints out the areas of the right upper lobe with the PA and a lateral, the right lower lobe with a PA and a lateral, the right middle lobe with a PA and a lateral. These are going to be your beneficial ones. I like the line ones too, but this is the shaded area, okay? Your left uppers and your left lowers. I've given you all of these to sort through, okay? Same CT, or we talk about the lung window versus the non-lung window, the soft tissue window. Look at how beautiful those lungs are on that lung window when I want to look at lung tissue. Not going to make you pull out fissures, but here they are. I might on the CT scavenger hunt at the end of the class just for funsies. Just for funsies. But I won't make you pull it out on the test. And then this is just one last slide just to talk about the hilum to understand everything that's in there and why it's in those areas. We're about to finish. More labeling. That's it. I know that was fast and furious, those last 10 slides, but it was really just because it was stuff we already talked about and giving you guys more tools to use and to study and to look at and to try to understand the areas of the lungs, okay? This is one of the most important lectures. If you don't understand what we talked about today, can't see what we talked about today, please let me know. Because understanding this is imperative to seeing all these abnormalities we're going to look at later in the block. Okay? I'll stay up here for a few questions. You guys have a wonderful weekend.